Okay, we're going to cover the leg, ankle, and foot in this lecture. And when we're talking about leg, I mean the anatomic leg, basically between the knee and the ankle. Not a whole bunch on the leg. Here's normal radiographs. We can see here's the lateral. You can see the tibia and the fibula. Here's the AP, tibia, fibula, basically. That's all there is to it. Really straightforward. There's a couple injuries. I know we've seen some previous fractures in the long bone fracture lecture, so I'm not going to go over those a whole bunch. A couple of fractures I do want to cover. First is the Mason-Noonan fracture. This is a fracture that in which it actually presents as an ankle sprain. What happens is they do some sort of twisting injury, and the forces travel, injure the deltoid ligament, then travel into the ankle, injure the syndesmosis ligament, and then travel up the syndesmosis, and then come out, in this case comes out in the distal fibula and causes a fracture there. More common is a proximal fibular fracture. This is found, this x-ray put it in because it shows both the injury to the syndesmosis, which we'll go over when we get to the ankle a little better, but this is not normal, this much gapping. More commonly, we're going to see an example like this where we've got an ankle injury with abnormal gapping, and then a proximal fibular fracture up here. And the big thing that I want to stress on this is that for any ankle sprain, you need to palpate the whole fibula to make sure you're not missing one of these fractures. Another special type of fracture is called the toddler's fracture. This is a fracture that, as the name suggests, is young children, and basically it's a falling, twisting injury. And you can see here it's a spiral fracture of the tibia. You can see it right here as well. So that's a so-called toddler's fracture. Tibial stress fractures, just the typical stress fractures look, if it presents normally, we can see increased sclerosis here and here, suggesting that this is a fairly old injury, at least 6 to 8 weeks before we're going to see any sclerosis like that. A more concerning type of tibial stress fracture is what's called here the dreaded black line. You can see it looks like somebody took an axe and just chopped out a little piece of the anterior tibia. When these are present, that's a bad sign because these tend not to heal well. Most tibial stress fractures heal with just fine with rest and then gradual return to activities. This dreaded black line suggests the possibility of basically a non-union kind of concept in a stress fracture. And these, here's another case that's even worse. We can see multiple different dreaded black lines here. These actually, in the most time, need to be treated with surgery, and what they typically do is they actually drill holes through the black lines to try to get this area to heal. The trauma due to the drilling stimulates the healing process and gets, hopefully, it to heal. Sometimes the other option is to put a tibial rod down. Okay. Typically, the x-rays are going to be normal if we're dealing with a tibial stress, we're concerned about a tibial stress fracture. And so then normally, the next test that we do is a bone scan. And the big differential that we need to be concerned about most of the time is that with the tibial stress fracture is medial tibial stress syndrome, which is more of a insertional or a tendinopathy kind of situation at the origin of the deep muscles off the medial edge of the tibia. In stress fracture, the bone scan is going to be dark and very focal increased uptake, and this happens to be just the way they did it. The uptake is black in this one, and this one the uptake is white. But notice that all along the tibia here, there's increased uptake, and there's no real focal area, and so that suggests that this is medial tibial stress syndrome, and this is a tibial stress fracture. Okay, like I said, not much to say about the leg. Next is the ankle. Here's the normal x-rays. We do typically 3 views. An AP view, a lateral view, and then a mortise view. The AP is just what it sounds like. It's just straight on. And again, not a whole bunch to identify. Tibia, medial malleolus, fibula, lateral malleolus, and talus. Here's the lateral view, and again, we've got tibia, fibula, talus, and the talar dome here. And then we can also see this calcaneus. Now the third view is called the mortise view, and where that comes from is the concept of a mortise joint that's used in furniture making, where we have this notch here that goes in this groove, and it makes a fairly strong joint. We see the same thing, same concept here with the mortise of the ankle. And so the mortise view is a oblique view that instead of, as we saw in the AP view, sorry, I have to go back here, there's overlap and it's hard to see some structures sometimes. In the mortise view, there should not be significant overlap as we look at this, what's called the mortise, this area around the talar dome. And in a normal case, the space between the talus, the medial malleolus, the talus, the tibia, and the talus and the fibula all should be relatively the same. So this is a normal mortise view. And this also allows us a much better view of the talar dome because of no overlap. And then there's everything labeled. Now, we're going to talk on Saturday about ankle sprains and when you need to do x-rays and when they're not needed. And obviously if it's just an ankle sprain, the x-rays are going to be normal. One thing that's included in the differential for an ankle sprain is a syndesmosis sprain, and the best way to evaluate that is actually on the mortise view. Again, here's the normal x-ray next to this with the space around the talar dome is fairly symmetrical. Here in the syndesmosis sprain, we see wide gapping here. I mentioned that earlier when we talked about the Mason-Nude fractures. That suggests that there's been disruption of the mortise. To have this happen, there has to be injury to the syndesmosis ligaments here for that gapping to occur. One way to make it, and if you see this is a grade 3 syndesmosis sprain. Now, grade 1 sprains on X-ray will be normal, but they clinically act like a syndesmosis injury, so you treat them as such. Grade 2 is one where the normal X-ray is normal. So here, again, spaces around are fairly symmetrical, a little bit narrowed here, but this space here and this space here are fairly even. What you can do is do what's called an external rotation stress view, where you do basically a Kliger's test. You put the ankle in full dorsiflexion and then rotate it laterally and see if any gapping occurs. And here, again, this is at rest, and this is with stress, and you can see that there's some gapping here that wasn't here, and that suggests that this is a grade 2 syndesmosis injury. Most grade 1 and grade 2 sprains can be treated conservatively. The grade 3 syndesmosis injuries need to be treated operative generally, because the ankle is unstable. And this is normally what they do, is they just put some screws across the joint to make the mortise joint and stabilize it so that it can heal properly. Okay, now we'll talk about when to do X-rays with ankle sprains on Saturday, but here's just a couple of X-rays that if we have somebody who's got what seems to be like a normal ankle sprain, but they're not getting better, what can we do? So a couple of things. First, is it, and a lot of times they say that they're having instability issues where the ankle's giving way, or they're having chronic pain. Now, while these views will show some abnormalities, the most common reason for chronic instability or pain is inadequate rehab. But certainly we can see true instability of the joint, and we can do stress views to evaluate that. So here's an example of basically doing what you do is the X-ray while taking the X-ray, you do, in this case, a Taylor tilt test at rest, normal, and then it opens up significantly, suggesting instability. Or you can do an anterior drawer test, again, normal, before stress, and then after stress you can see the talus transfers significantly anteriorly, suggestive of instability. These would be suggestions if they've already gone through an adequate rehab program and have not responded, then surgery may be indicated. We can also see talar dome injuries. Here's an example of basically a piece of the corner of the talar dome is injured, relatively subtle change. These are commonly missed. Here's an example of a case that I found in an article where the initial film after the X-ray was a little bit abnormal. There was this little piece here that was suggestive of maybe there's an injury, but it was read as normal. He was treated as a typical ankle sprain, and his pain gradually got worse and worse over years. He returned for follow-up about 7 years after the injury, and you can see that there's arthritis in this joint. It's not as rounded as it was, and there's some bony abnormalities through here. And then they did the MRI, and you can see this whole corner is abnormal and disrupted, secondary to the talar dome injury. These are most commonly going to need surgery. And unfortunately, this case is going to be even harder to treat because it's old. Talar neck fractures. This is something that I have seen a couple cases of, in people who are wearing an ankle brace, and then they still sprain their ankle. And what happens is that the ligaments right through here are supported by the ankle brace, and so the forces are transmitted just outside the brace into the talar neck. And this all should be just like this color here. This is all white as bone. The whole talus here should be that same color, but you can see this, the darkness suggesting fracture and edema. So think about this as a possibility of somebody who sprains their ankle while they're wearing a brace. Some other possibilities, the book talks a little bit about these. Anterior impingement, we can see osteophytes being formed on the talus and the tibia here, and this is what's called the kissing lesion. If you would have them maximally dorsiflex, these 2 points would abut and cause pain when they're going into full dorsiflexion. We also see posterior process talus, fractures of the talus. This little piece here, you can see a fracture line right there, and they're going to have posterior pain after ankle sprain. And the test that often helps with this is to put them into, force them into maximal plantar flexion relatively quickly, sort of whipping the ankle, and if that causes posterior pain, think about this as a possibility. Okay. Ankle dislocations, these are fairly easy to identify both clinically and with x-ray. You can see here's the talus, which should be here, and it's not. You can see fractures around the ankle. There's 2 specific ones that I want to talk about: the bimalleolar fractures, where we see fractures of both the medial and lateral malleolus in this case, and then the trimalleolar fracture, which there's not 3 malleoli, but they still call it this. We got a medial malleolar fracture, lateral malleolar fracture, and then on the lateral we can see the posterior corner of the tibia is knocked off as well, and that's when they call it a fracture, a trimalleolar fracture. That's what they're talking about. And obviously all of these are going to be unstable fractures and are going to need surgery in most cases. Okay, moving down into the foot, we've got, again, 3 views that are typically used for this. We've got the AP, and you can see the various structures that can be seen with that. The oblique, the main advantage of the oblique is, if you can see, there's a lot of overlap of all the joint lines here in the tarsal bones, whereas the oblique view, you can make out the joint lines much easier. And here's the labeled version. And then the last one is the lateral. And again, here it is labeled. Okay, some issues with the foot: calcaneal fractures. Most of the time these are high velocity injuries. The classic one is a fall from a height. You can also see these in motor vehicle accidents. And here you can see fracture line through here. If a calcaneal fracture is suggested or suspected and the x-rays are normal, sometimes the x-ray findings can be very subtle. There's a whole sort of, there's something called Bohler lines, that's B-O-H-L-E-R lines, that radiologists use to try to identify if there's a fracture there or not. In most cases, however, what we want to do is, if it's suspected and they're not responding to treatment, consider a CT, because that's going to be the most sensitive way to assess this. Heel spurs are very common, and a lot of times we correlate these with plantar fasciitis, and I'll basically what I tell patients is, if I'm diagnosing them with plantar fasciitis and they say, well, do I have a heel spur? I said, well, and ordinarily I don't do x-rays. And the reason for that is that heel spurs aren't going to change my treatment of the plantar fasciitis. So, because some people with plantar fasciitis have heel spurs, some people with heel spurs don't have plantar fasciitis and have no pain. So, it really doesn't help me a whole bunch. The main reason to do the X-ray would be if they've failed treatment and they're considering surgery. And some of these heel spurs are hooked. This one's not hooked too badly, but basically you can picture it basically, stabbing the plantar fascia. And if that kind of heel spur is present, then removing the osteophyte surgically may be helpful. But we certainly don't consider doing that until they've failed conservative therapy. Okay, moving distal, navicular stress fractures. The navicular stress fracture is fairly common. It's 25% of all stress fractures of the foot. Most are metatarsal stress fractures. The problem with the reason navicular is at risk for this is because we've got twisting. We've got forces there. The arrows don't show up real well here, but there's twisting forces, and so the middle third of the navicular has these twisting forces on it. It also happens to be avascular, so it doesn't respond to stress real well, and that's where those stress fractures tend to occur. Most of the time, just like most stress fractures, their x-rays are going to be normal. Bone scan is very sensitive, and here we can see this area of the navicular lighting up. But if there is a navicular stress fracture, you want to proceed to a CT scan because that's going to help guide treatment. This is a grade 1 stress fracture where there's just a little fracture line but does not go all the way through. Here's a grade 3 where there is a fracture line all the way through. The smaller arrows here are actually pointing to a tarsal navicular coalition, where the reason for this stress fracture happened to be the fact that those bones were fused and the navicular didn't move properly. Grade 1 stress fractures can be treated non-weight bearing for 6 to 8 weeks, but a grade 3 stress fracture is going to need surgery and is rarely going to respond to conservative therapy. Next thing is the Lisfranc fracture and dislocation. This was named after Napoleon's chief surgeon for his armies, and the reason he recognized this injury was they had cavalry injuries where a soldier would be on the horse and then thrown off. The foot would be caught in the stirrup and then it would injure this joint. And basically this is a joint complex with the first, second metatarsals and the first, second cuneiforms is the Lisfranc joint. And unfortunately at that time, when this injury occurred, the treatment that Lisfranc suggested was actually amputation at that joint, because there was no treatment that had any success at relieving pain. They just would have chronic pain for the rest of their lives and often would become crippled for it. So how do we identify these on x-ray? Is basically the biggest thing is a gap that we see between the first and second cuneiform that we normally wouldn't see, and there's often a fracture. Here's a teeny little chip fracture here and a teeny little chip fracture here, so very subtle changes. And here's some other examples. Here's you can see a fracture there on the second cuneiform. On lateral, sometimes we can see actually a step off between at the edge of the first metatarsal. Ordinarily, this should be flat right through here, and there's this step off here, suggestive of a possibility of a Lisfranc. There's a couple of different ways to diagnose this if the x-rays are normal, because they often are. First thing, the easy way is to do an MRI, but another option is to do non-weight-bearing and weight-bearing films. Here's an example of a patient. These are non-weight-bearing, and then the films are repeated with weight-bearing. This is the injured side, and you can see if we go back here, there's really, there's a little bit of a gap here, but there's a little bit of a gap here. Here the gap widens significantly, and also if you follow a line along the second metatarsal, it should line up with the cuneiform. Like over here, if you just draw this line, it is nice and smooth. Here there's a step off right there that shows that this joint is unstable and needs treatment. And how do we treat these? Grade 1s, which is normal x-rays and normal weight-bearing films, or MRI that shows no true diastasis, but there is injury to the ligament. And again, this is basically if they're tender over that joint and have pain with valgus or twisting stress to the joint. If there's any gapping at all with weight-bearing, or the x-rays are abnormal at rest, then that suggests that they need surgical treatment. And here's an example. And this is a major issue and major surgery with all these screws to stabilize this joint. And the problem is that if they don't get this fixed, then they're going to have chronic foot pain and may lose the ability to walk. Metatarsal fractures, we've shown these before with the long bone fractures. Here's 2 fractures here. These, if there's one bone involved, typically they can just be treated with post-operative boot or a walking boot just to give them pain relief, and they heal up pretty well. If there's multiple fractures in different metatarsals, then surgery sometimes is needed to be done. Now, I want to spend a little time on the 5th metatarsal, because there's basically 3 different fractures that we can see with the 5th metatarsal that are important. Now, a mid-shaft fracture, which I'm not going to talk about a whole bunch, this is basically treated just like any other shaft fracture. The ones that are important to catch, the Jones fracture, this is a proximal 5th metatarsal fracture that occurs basically at the junction of the shaft and the base. And then an avulsion fracture, which is a fracture at the tip of the 5th metatarsal that is due to ligaments pulling off the piece. So here's an avulsion fracture right here. Typically, the mechanism for an avulsion fracture is an ankle sprain mechanism, an inversion injury. And instead of the pain being present at the ankle, the pain is present on the 5th metatarsal. Now, one thing that's commonly mistaken is this situation where they call it, this is called an avulsion fracture. But in actuality, this is just a growth plate that has not fused. And sometimes it never fuses, and it stays as a ossicle. The main differences between the way you can tell the difference between a growth plate and a fracture is that the growth plate is going to be parallel to the shaft, whereas, the avulsion fractures are going to be perpendicular to the shaft and typically are going to get into this fifth metatarsal cuboid joint. So that suggests a fracture. This is normal. Now, treatment for these, even with this, most cases can be treated just like any normal ankle sprain and then heal well. Now, the Jones fracture, the mechanism for this is generally a fall on the outside of the foot. Classically, we see this a lot in dancers. It's not a twist of the ankle, but if they're up in the air and then they come down on the outside of the foot. And you can see the fracture here. This is an avascular section of the bone, so it does not heal well. And typically we need to treat these very conservatively. Sometimes they'll try non-weight bearing cast for 10 to 12 weeks, but more commonly they'll go ahead and just put a screw in across it to get it to heal properly. Now, if we get a stress fracture in that location of the Jones fracture, this sometimes is called, they'll say it's a Jones stress fracture, which is not really the correct term, but it's a stress fracture at the location of a Jones fracture. If those occur, again, these do not heal well and typically have to be treated with screws. Okay, moving distally a little bit more, hallux rigidus. This is basically severe osteoarthritis of the first MTP joint. You can see loss of joint space, osteophytes, and they don't bend at the toe very well and thus have difficulty and pain with ambulation. Hallux valgus, also known as bunion. This is primarily a genetic condition. It's been blamed on this, more common in women, and so it's been blamed on the narrow shoes. And the shoes don't really cause the problem with the bunion. What happens is as the bunion gradually occurs, and basically we just see that this metatarsal starts to go medially, it widens the foot and makes it more difficult to wear narrow shoes. So it's not that the narrow shoes cause the bunion, but it's the narrow shoes cause symptoms with the bunion. The other thing is that we don't see as much problem in men with this as women, primarily because men wear wider shoes, and so they don't have as much pain, and so they don't present with it as often. The ways to diagnose a bunion is look at two different angles. First is this intermetatarsal angle, where we measure the line along the first metatarsal shaft and the second metatarsal shaft. Anything over 9 degrees is considered abnormal. And then we also can measure the angle between the metatarsal and then the phalanx. Measure that angle. That's the metatarsal phalangeal angle, and if it's over 15 degrees, then that's abnormal. And here's an X-ray showing the intermetatarsal angle of 18 degrees and a metatarsal phalangeal angle of 31 degrees, so obviously an abnormal X-ray. Now, treatment for surgery for bunion is surgical in most cases. This is and some podiatrists will do what they call a bunion resection, where they basically just cut off the outside of the metatarsal head, which makes the bunion smaller but doesn't affect the progression, and the bunion is going to just continue to grow and is the temporary fix. So the best surgery is to do an osteotomy, or a cut through the bone. Here's an example of this is the same patient before surgery and after surgery. You can see how much straighter this is. And what they do is this line here shows the cut. So they basically make this diagonal cut in the metatarsal and then shift the metatarsal head medially to straighten things out, and then put a screw across the cut so that it will heal properly. And the last disease is Freiberg's disease. Basically this is sort of like an avascular necrosis of the metatarsal heads. Most commonly is going to be seen in the second and third metatarsals, but can be seen in any of them. And you can see the normal metatarsal head here should be relatively rounded, and here it's flattened, and then they have pain at that joint. And here's an X-ray that shows a progression over time. This is the initial X-ray. You can see that that's fairly rounded, and we're starting to see some flattening and some abnormalities there, and now it's squared off. So that's just another disease that we see that causes metatarsal pain. That concludes this lecture.